Assalamu alaikum, this is Shama Tuzara, and today my topic of discussion is the cardiac tamponade. Now, basically, in this video, we'll discuss that what is cardiac tamponade, we'll understand the whole pathophysiology of the cardiac tamponade, how it causes effects on our body, and what sort of effects they are, and we'll relate the pathophysiology of this disease to the clinical features by which the patient presents to us. So this is basically our main discussion today. And so starting our discussion, first of all we talk about the definition of cardiac tamponade. Now, what is cardiac tamponade? It's very important to understand. So basically, first of all, it's not a normal condition. Like, of course it's not a normal condition, it is a disease, but it's not at all less severe disease. It's a medical emergency in which there is presence of fluid in the pericardial cavity that impairs the diastolic filling of the heart. So imagine these is the heart, it's two ventricles. Suppose this is the right ventricle, this is the left ventricle, and around it this is the whole two layers of pericardium. Fine. So this is the pericardial cavity. Now, in this disease, because of many reasons, we'll discuss the causes later on, but because of many reasons, what happened that fluid gets accumulated in this pericardial cavity. So what is this golden color? This is the whole fluid within the pericardial cavity. Now, what will happen? Imagine, to understand this concept, just imagine that suppose if this is a tank which is full of water and I have placed a semi inflated balloon within it. So this is a balloon and this whole tank is filled with water. Fine. Now just imagine that I am trying to fill air in this balloon. Now, when I'm trying to fill air in this balloon or I'm trying to inflate this balloon, what will happen that this balloon will face resistance because of this water around it. So, what will happen that it will be unable to dilate properly, will unable to inflate properly. So, this is the main concept which we will apply on the cardiac tamponade on our heart ventricles around which the pericardial cavity is now full of fluid. So fine. Now what will happen that at the very start of the diastole, these ventricles, of course, they will receive blood from their respective atrias, right ventricle from the right atria and left ventricle from the left atria. So when they are receiving blood, of course they will dilate. Now what is happening in this condition is that since there is fluid around the pericardial cavity, so the ventricles, they are unable to dilate properly. Fine. So when they're unable to dilate properly and more blood is coming in, what happens that the diastolic filling pressures within the chambers, the diastolic filling pressure is now increased. Why? Very common, because of course this increased pressure has to be compensated by the dilation of the ventricles, which is not occurring properly in this disease. So the inside of the ventricle pressure will increase, and when this pressure will increase, it will equalize the ventricle wall. To prevent itself from rupturing, what it does will that it will equalize the pressure in all chambers of the heart, of course, because the ventricle has no other option, because it can't dilate properly because of the fluid in the pericardial cavity. So the pressure, this increase, first of all, diastolic filling pressure is increased. Now this increased pressure is then equalized within all chambers of the heart, and as a result the pressure of all the chambers of the heart, like right atrium, right ventricle, left atrium, left ventricle, the ejection system, that is the pulmonary arteries of the right ventricle, plus the pericardial pressure, intrapericardial cavity pressure, these all pressure are now equal. So this is a characteristic feature that occurs within the cardiac tamponade. Fine. So this is the thing that has occurred in the disease. Now some very basic concepts, but we'll relate here and they'll bring very big changes to us. First of all, in the cardiac tamponade, which part of the heart, means either right ventricle or the left ventricle, which is more affected? Now if I say that right ventricle is more affected as compared to the left ventricle, then I'll think that of course you'll get this point. Why? Because the right ventricle, first of all, there are many points. Right ventricle wall is thin, first of all. Second, right ventricle is a low pressure area. Thirdly, because of these two factors, it can easily be compressed. Of course, the part that is weak, the part that is thin, we can easily apply pressure over it and we can compress it up. Same as in our normal lives, the person who is a bit weak, the person who is a bit shy, you can say, we can easily suppress, or he can be easily suppressed by a person who is more dominant. So that is the thing that is applied here. And in contrary, the left ventricle, as we know, its wall is thick, plus it is a high pressure area, so it is less compressed by the fluid in the pericardial cavity. Fine. So I think now this point is clear that why right ventricle is more affected in cardiac tamponade as compared to the left ventricle. Good. If you still have any question, you can ask me in the comment section. Now, another important concept that this I have repeated in my a lot of videos, so I'll just give a brief overview here, not in more detail. So, what happened during the inspiration? Now, during the inspiration, the blood flow, or you can say the venous return, I'll write with another marker so it's differentiated. The venous return coming to the right atrium, and hence the right ventricle is increased. Now why it is increased? I've already discussed that when you inspire, the thoracic cavity expands, as a result lungs expand, so the lungs that were applying pressure on the right atrium will now no longer apply that pressure. As a result, superior vena cava increased pressure compared to the right atrium caused the inflow of blood rapidly and more increased than normal into the right atrium. So venous return is increased. Second point, the diaphragm moves down, it applies pressure on the inferior vena cava, so the pressure is increased in the right atrium and hence the right ventricle. But now, okay, what is happening here, that our right ventricle is not normal. Our right ventricle is not normal. In fact, the ventricle is normal, but its conditions due to the pericardial cavity, it doesn't dilates normally, or the diastole phase is affected. So what will happen, that if I show you the heart, it's ignore my drawing, but if I make this is somewhere the heart, the two chambers, the septum, so just imagine it is a heart. I know it doesn't look so, but okay, suppose this is the right side, the left side, right atrium, right ventricle, left atrium, left ventricle. Now I've told during inspiration venous return increase to the right side. Now suppose this blood is coming more and more, and now this ventricle can't expand, so it can't accumulate this increased amount of blood. As a result, there is backflow of the blood. So first point what is occurring here is that there is backflow of blood towards the right atrium from the right ventricle. Why? Because right ventricle can't accommodate this extra amount of blood within it. Fine. So this backflow of blood, first of all, what it causes, periodically it causes right atrial dilatation, and this backflow causes increased amount of blood pulling up back in the venous circulation, both the pulmonary veins as well as the systemic veins. Now when this thing happens, what is basically happening, that the venous return coming to our heart, to the right side of the heart, is now reduced. So first point, venous return is reduced. This is a very important point. I'll make 3 takes over it. Fine. When this pressure is reduced, for now all the symptoms which will appear in this patient, now I am merging the pathophysiology with the clinical features. Now, in this state, all the features will appear because of this reduced venous return. Fine. Now, taking another pen, what will happen with this reduced venous return? When the venous return is reduced, there is backflow in the blood in the pulmonary veins and the systemic veins. Now, because of this backflow of blood, what will happen? Will our neck veins be dilated? Of course, yes. So, neck veins will be dilated. Will the jugular venous pressure within the neck vein, particularly on the right side? Why? Because right side is more affected. So, the right side, particularly JVP, jugular venous pressure, will be raised. Of course, yes, it will be raised. Now, another important point. Jugular venous pressure is raised normally. We know why, because there's backflow of blood. But if we consider that during inspiration, we know increased venous return is coming. But that increased venous return is not accommodated by our heart, so it is moving back. Now, when it is moving back, so during inspiration, there is more increase in the JVP as compared to the normal. Fine, because increased blood is coming during inspiration. So, third will be an important point, that is called the Kussmaul's sign. Now, what does this sign say? That it says that during inspiration there is paradoxical rise in the JVP, as I have explained before why, during the inspiration. This phenomena is called the Kussmaul sign, and it is not just present in the cardiac tamponade, it is present in all those diseases in which the right heart failure is occurring or the right ventricle is not able to dilate properly. So, in all those cases, the Kussmaul sign will be seen. Now, moving forward, what else we will see, that because of this backflow of blood in these all veins, we can also see the signs of fluid overload. Why? Because now fluid is accumulating in our body. Fine. So the signs of fluid overload will be gradually edema will develop in the body, and it's a complication of this disease that in the lungs edema will develop, that is called pulmonary edema. It can be seen in this patient. So these are the all sign and symptoms that will observe in the patient. Why? Because of this one primarily defect, that is reduction in the venous return. Now hold on, one other process that will occur, that same during inspiration, what will happen, that less venous return is present in this right ventricle, so less amount of blood will move from the right ventricle to the lungs. And this because the right ventricle empties into the pulmonary artery, and that pulmonary artery goes to your lungs. From there comes to pulmonary veins into the left atrium and the left ventricle. So first of all, since already during inspiration, now I've repeated this concept a lot of times, so I won't spend more time over it. You can listen my previous videos for better understanding of this concept, but I'll just give you a brief overview that what happened when in the same time venous return is increasing during inspiration, at the very same time the blood coming to the left atrium is reduced. Why? Because lungs are now expanded. Because of expansion of the lungs, pulmonary veins are dilated, and when a vein is dilated, it will have less pressure within it, so less blood will be ejected and comes to the left atrium. So what's happening, that in the left atrium less amount of blood is coming, comparable to right side, less amount of blood is coming, less will move to the left ventricle, and hence less will be ejected. So what will happen, that first of all, of course, I'll make this again on the next page. So we'll differentiate venous return sign and symptoms from decreased cardiac output sign and symptoms. Fine. So let's moving on to our second part of the basis of the clinical features. So imagine this is again that heart. Fine. This now we will more considering the left side of the heart. So because of during inspiration, due to pulmonary veins dilation, less blood will reach the left atrium, and that less blood will come to the left ventricle, and hence that less blood will be ejected. So stroke volume ejection fraction and the cardiac output all will be decreased. Now, what is stroke volume? The amount of blood ejected by the left ventricle with each contraction. That is called stroke volume. Ejection fraction is the amount of blood ejected by the left ventricle. It's not amount, it's the percentage of blood ejected by the left ventricle during each contraction. And when we multiply this stroke volume by the heart rate, it becomes the cardiac output. The amount of blood ejected by our left ventricle per minute, not per beat, per minute. So yeah, what is happening? Less amount of blood is coming, less already during inspiration this hole is reduced, and resultant to this hole what will happen that our systolic BP will reduce, and this reduction is in normal conditions it is less than 10 mm of mercury, which is considered as perfectly normal because it's a physiological mechanism. But hold on, what is happening here that this right ventricle is ejecting less blood. So this less blood is then through passing through pulmonary arteries and lungs to pulmonary veins into the left atrium is receiving now more less than normal. Already during inspiration blood is less doing left to the left atrium and to the left ventricle, and in this particular condition further, so I'll write here that further less amount of blood will be coming to the left ventricle and hence ejected. So when the ejection fraction, cardiac output and the stroke volume are further reduced than this state, what will happen that this reduction in the stroke volume, reduction in the systolic BP reduction will be now greater than 10 mm of mercury, and when this thing occurs it is called, I'll write it in bold, it's very important, it is called pulsus paradoxus. Now what is pulsus paradoxus? That decrease in the systolic BP of greater than 10 mm of mercury is called pulsus paradoxus, and it is a characteristic feature of this disease, pulsus paradoxus. Now basically this second part of our pathophysiology, what is happening here that because of everything that I explained, net is that cardiac output is reduced. Now the second set of symptoms that will appear will be because of this cardiac output. So starting our discussion that what will be the sign and symptoms due to this pathophysiology, imagine the cardiac output is now reduced. First point, that less blood will be ejected into the, of course left ventricle has to eject blood into the aorta, so blood coming to the aorta will be less, so the BP, and we know that systolic BP is measured by the blood within the artery, right? So BP will be reduced. So first point will be low BP, or we can say hypotension. Okay, fair enough. Because of this low BP, as we know that within the aorta there are some baroreceptors. Now when this low BP is detected by these baroreceptors, they cause reflex tachycardia, and this reflex tachycardia we can write that heart rate is increased. Yes, we can write it. Very good point. Third, now this decreased amount of blood, decreased cardiac output containing less amount of oxygen is now supplied to the tissues of our body. So the tissues will of course present with the signs of anemia or low cardiac output or low oxygen receiving or low nutrients receiving. Get these all points? So what will be the sign and symptoms? That patient will feel fatigue. Fair enough. Why fatigue? Because he is receiving less oxygen, less nutrients and is forming less energy, so he will become lethargic, he is fatigued. Secondly, since less oxygen, so there will be dyspnea on exertion. Third, patient can't exercise a lot, so there will be low exercise tolerance. Okay, now these are the signs and symptoms that appear. Now as we know that it's a very basic concept that whenever there is less oxygen, now what is happening that the body is whole crying, like suppose this is my whole body and it is all crying that please give me more oxygen and nutrients, I badly need them. So what it does is that as a reflex to it, first of all, we have only two organs of our body that can provide this enough oxygen to the body. One is our heart and the other is the lungs. And whenever there is less oxygen in the body, these two organs, what they do is that heart has only one ability, it can contract more. Fine. So heart rate will be increased. Okay. Lungs will undergo contraction and relaxation more, so breathing rate will be increased. So patient will also have increased heart rate, increased breathing rate. Fine. Now moving on to that, what effect will be on my heart sounds. So this is a very important concept. I'll explain you here. First of all, you should basically know that what are heart sounds. Fine, what are heart sounds? Heart sounds are basically the sounds produced due to closure of the valve. And we know we have 4 valves in the heart, basic valves. So whenever the valves close, some sounds are produced and that we hear on auscultation. Thrust, we already know that. Now you can say the amount of this sound or the voice basically of this heart sound, it depends on two major factors. First of all, what is the end diastolic volume of the chamber, plus what is the isovolumetric contraction. Now I'll explain you this thing. What is happening in our current disease, that there is less filling within the left ventricle plus the right ventricle, so end diastolic volume is reduced. Now according to the, I'll write here that according to the Frank Starling law, we have read in our pathology, in our physiology, that what is Frank Starling law. Whenever there is, of course, reduced end diastolic volume, whenever there is reduced stretch of the muscle fibers, this reduced stretch is directly proportional to decrease in the force of contraction. So applying this concept here, that since end diastolic volume is reduced here, muscle fibers will stretch less than normal, and what will happen, the isovolumetric contraction, its magnitude will also reduce. And now when both the factors determining the sound are reduced, so net would happen that the heart sounds, they are slow, you can say they are soft, and the most appropriate word or the most appropriate term here is that we hear muffled heart sounds, and it is very important here. Plus another feature that is important and we should know is that if some inflammation is present in the pericardial walls. Now if inflammation is present, then during each contraction, both, suppose these are the two walls, parietal pericardium and the serous pericardium, whenever they are inflamed, suppose, so what will happen, that with each contraction they will rub against each other and a pericardial rub is heard, and sometimes this pericardial rub is so loud, it is basically a sound, grating sound, you can say. Which sort of sound it is a grating sound. This sound is so high that it can even mask our normal heart sounds too. So these are basically the signs and symptoms that will appear in the patient with heart disease, named cardiac tamponade. Fine. So all set of symptoms are basically based on two major pathologies: decreased venous return, decreased cardiac output. I hope you have understood this whole concept which I have tried to share with you. So at the end, just a brief summary of what we studied today. We studied what is cardiac tamponade. Cardiac tamponade is basically a condition in which there is presence of fluid in the pericardial cavity that impairs the diastolic filling of the heart. Now, one very important point that I'll write here as a star, that as we know, you have heard my previous video most probably, and if not, go ahead. In constrictive pericarditis, what happens, that in it there is also diastolic filling of the heart affected, but in it early diastole is normal and late diastole is affected, and late diastole you can say is abruptly stopped. But in the cardiac tamponade, the diastole, from the very start of the diastole, it is impeded because there is fluid in the pericardial cavity. So in cardiac tamponade, the diastole is affected throughout its whole phase of relaxation, but in constrictive, early is normal but late diastole is affected. So we studied next that right ventricle is more commonly affected by, as compared to the left ventricle, and there is two main pathologies. First is reduced venous return, second decreased cardiac output. Due to reduced venous return, sign and symptoms that appear are neck veins will be dilated because of backflow of blood, raised JVP, Kussmaul sign will be present, paradoxical rise in JVP during inspiration, and fluid overload sign that cause pulmonary edema and the edema throughout the whole body. And secondly, we studied that main point is reduction in the cardiac output, and due to reduction in the cardiac output, what features will appear, that there will be pulsus paradoxus in the patient. Patient will have low BP, means hypotension. Patient will have reflex tachycardia. Anemia sign will be present like fatigue, dyspnea on exertion, low exercise tolerance. Breathing rate will be increased, heart rate will be increased, heart sound will be muffled heart sound. The mechanism I've explained you before. Now a very important point here, just a last note to my all discussion, that there is Beck's stride. Now what is Beck's stride? I have made full-fledged video on it, so I won't discuss in detail here. And to understand the whole mnemonic, to memorize it, I'll share the link in the description box, so please do listen it. What is Beck's stride? In it there is low BP, means hypotension, elevated JVP, and third feature is the soft heart sounds, or you can say muffled heart sounds. So these three, they collectively form the Beck stride, and Beck stride is characteristic feature of cardiac tamponade. On this note, I end my discussion. Thank you very much for listening. I hope you liked the video. If yes, then please like, share and subscribe, and maximum share with your fellows. Any queries, please ask me in the comment section. Thank you so much. Allah Hafiz. See you in the next video.